afternoon, everyone. Welcome to the Healthcare Leadership Council's briefing on optimizing value-based care. We're excited to be hosting this conversation as our members prove every day that value-based care is a vital way to improve health for people everywhere. Secretary Kennedy's focus on chronic disease aligns with this approach, so that's been a key area of engagement that we've been having with HHS leadership and other policymakers. So today's conversation is an important step in continuing this dialogue with even more stakeholders. So thanks for joining. We see great untapped potential in value-based care and in that approach, and we aim to inspire further discussion and action. HLC, in case you don't know us, is uniquely positioned to convene this discussion, as our membership is composed of healthcare CEOs and C-suite executives from across the care continuum. So we're excited to have three of those prominent leaders with us today. They are three leaders in the value-based care space. They'll share insights into the future of the approach and industry innovations. So our panelists are Barry Arbuckle, President and CEO of MemorialCare, Dr. Wyatt Decker, UnitedHealth Group's Executive Vice President and Chief Physician, Value-Based Care, and Kyle Wailes, who is the Chief Executive Officer of Wellvana. Thank you all for joining us and sharing your time and expertise. Now, before we get started, just two items I want to mention. First, in case you didn't see it, this session, we will be recording today's discussion, and we're going to share it with all of the attendees and through HLC's digital channels. And second, for the participants, if you have questions throughout the conversation, just drop them in the chat, in the Q&A function. We will try to answer as many of the questions as possible, but we won't be doing that until the end of the discussion. So let's get started. Okay, Barry, we'd like to begin with you. So could you articulate your perspective on the strategic imperative of value-based care? What measurable progress has been achieved since its inception, and where might critical opportunities for further advancement lie in order to really capitalize on the promise?
Absolutely, and thank you for that. First, I think it's important to briefly define what we're talking about. Value-based care is all about value, more for less, greater access to care, emphasizing the key role of the primary care physician, better quality and at lower cost to the consumer, to the employer, to the government. And value-based care comes in a number of forms. I know Kyle's going to talk more about that in a few minutes. We call them alternative payment models, and they include ACOs, capitation of providers, even direct-to-employer contracts, all having similar characteristics of aligning the incentive of the patient and, frankly, our overarching health system with the provider system, better health and faster recovery, the right side of care at the right price. As the industry has begun to pivot away from fee-for-service, which simply defined involves paying providers more when people are sick or injured and paying for every test and procedure, we're seeing more and more documentation of the benefits of value-based care. I'm going to share one, knowing that we're going to have time to unpack a few during our time together today. My health system is in California, where we've been taking risk for decades. The Integrated Healthcare Association is a California-based cross-sector company that's collecting and analyzing data on this for the last 2 decades. The results are wildly compelling in favor of value-based care products. What they've seen, when providers take risk in an HMO or a PPO product, quality increases by 15 percentage points across 9 clinical measures. And the cost of care in those risk-based products is 40% lower than in fee-for-service products. So again, we're going to be able to touch upon that more shortly, but I think there's ample empirical evidence to support the federal government continuing to take steps to encourage, in some cases require or incentivize, moving toward value-based care or alternative payment models.
That's great. Thank you, Barry. Those compelling statistics. So Kyle, the financial mechanics of value-based care, especially risk sharing, can sound abstract, even pretty complicated, I think, to a lot of people. Can you break down what we mean by risk sharing continuum, including upside versus downside risk, and how do organizations of different sizes and structures think about risk differently?
Yeah, thanks, Maria. Happy to break that down. I thought It might make sense just to level set for everyone. And let me start by highlighting what is meant by upside and downside risk. And then I can talk a little bit about the risk continuum from there as well. So in upside risk, providers can earn a portion of shared savings. And so this happens when a patient's actual medical spend is less than a patient's estimated medical spend, which is also known as the benchmark. And that benchmark is what's set by the payer themselves. These upside percentages can be 25% or less of the savings, all the way up to 100% of savings, depending on where you are in that risk continuum. Again, I'll talk more about that here in a minute. In downside risk, providers take financial responsibility for a portion of shared losses. And so this happens when a patient's medical spend is greater than a patient's estimated medical spend or benchmark, which again is set by the payer. If a provider is assuming no downside risk, then they pay back nothing in the event of a loss, all the way up to 100% of the losses if they're responsible for that amount. And so when we talk about the risk sharing continuum, ultimately what we mean by that is not every provider is going to be ready for risk, right? Not every provider is going to be ready to assume 100% of the downside risk on a patient's total cost of care. And so there's different programs that have different levels of varying downside risk, which typically correlate to an upside percentage of savings that's also changing. So that's going to start at 0% on the far left of the spectrum, where the provider is responsible for 0% of the downside and might get a small portion of the upside or savings, going all the way up to 100% upside and 100% downside for the most sophisticated providers that are out there today. And generally, the more downside risk that a provider is assuming, the greater percentage of the upside that they can earn as well associated with that. So that's what we mean when we talk about the risk sharing continuum.
Okay, great. Hopefully that helped everyone better understand what we're talking about here. So Wyatt, let's bring it all together. How does value-based care support key goals that are top of mind for this Congress and the administration, such as addressing chronic conditions, improving outcomes and affordability, and of course, reducing waste, fraud, and abuse? How can it help with all of those?
Yeah, Maria, thanks for having me, and to our audience, thanks for joining us. I'm going to start with chronic diseases. It's well known that we are a nation of chronic diseases. 60% of U.S. adults have one or more chronic conditions, which is substantially higher than benchmarks around other developed countries. So what are we going to do about this? Well, the challenge with the traditional fee-for-service system, which is the bulk of U.S. healthcare, is it waits until there's a significant symptom or even a crisis. I'm an emergency physician, and so often I would diagnose diabetes when someone's blood sugar was so high that it was causing severe symptoms, mental status changes, dehydration, etc. Why does the U.S. healthcare system struggle so much to get ahead of diagnoses like type 2 diabetes before they're a crisis, like heart failure or kidney disease before people are in crisis? And I would submit that the primary driver of that lack of preventive care and early diagnosis is we don't incent it. We don't reward it financially in fee-for-service. We reward doing things as a sick care system. So the way to get upstream is to take that step back, which is what you're hearing from Kyle and Barry today. Take a step back and say, how do we engineer a system that actually rewards healthcare providers and systems for getting ahead? And that's really what most value-based care constructs are aiming to do. They're aiming to create the financial incentives instead of to wait and do things when you're in crisis or severe problem. Get ahead of it and diagnose conditions when they're early and manage them effectively, because you may be on the hook if you have downside risk. You may be on the hook for that ER visit or that week in the hospital. And if you're on the hook for it, you're actually interested in getting upstream. And that's a powerful driver of incentives. And I think today there's too much talk about what's wrong with value-based care. Is it even succeeding? I would agree. Medicare Advantage, which we can talk about in a few minutes, is a great example of this. It needs to evolve and grow and be fine-tuned, but we should also recognize that the bulk of U.S. healthcare remains stuck in fee-for-service, which is transactional and delivering high volume, high cost care that's fragmented and of variable quality.
And that's a good reminder because we all spend a lot of time talking about this, but when you hear those numbers about how much is not there, it is alarming. So, okay, we've covered some of the basics of the model in serving patients, advancing outcomes, and what it can do. So let's move into the different roles your organization serves. So each of your organizations obviously approaches care differently, care delivery and value-based care differently, given who you are. Can you briefly share how your organization uniquely operates in the value-based care paradigm? So Kyle, we'll start with you because you're somewhat in the business, I think.
Sure. Yeah, happy to. So, we talked about fee-for-service already. We talked about value-based care. And so that's exactly where we sit, is in the enablement of the transition from legacy fee-for-service reimbursement models to a value-based care reimbursement model. We do this by partnering with physicians and healthcare providers. We don't employ any physicians today. And as part of our model, we do that really to ensure the following. First, we want to make sure that the provider is in the right risk program. So I talked about the risk continuum. That's really step one, make sure that the provider has the right level of risk to start out. And then two, making sure we're enabling them to provide the right clinical intervention for the right patient at the right time. And so as you think about those interventions, sometimes we do those on behalf of the providers. Sometimes we use data to help train clinical teams on how to deliver those interventions. And as I think about an intervention, it really means we're partnering with the patients who are most at risk. So it's the most vulnerable population. It's ensuring that the patient has the right care plan. It's supporting compliance and adoption of that care plan. It's connecting the social needs of the patient to those available that are in their community. All of which are ultimately going to deliver a better clinical outcome at a lower cost of care for the patient today. We're doing that largely in Medicare populations and Medicare Advantage populations across approximately $13 billion in medical spend or medical risk across approximately 1 million patients broadly.
Great, thank you. So Barry, how about you? MemorialCare.
Yeah, MemorialCare is an integrated delivery system. It's comprised of a teaching hospital, a women's and children's hospital, and several community hospitals. We have an employed physician division as well as an independent physician division that's aligned with the health system, aligned strategically, aligned financially, aligned clinically. We have an extensive network of ambulatory sites that are all off hospital license, which allows them to provide some of the same care at a lower price point. And we have, frankly, since the pandemic, an extensive virtual care portfolio that offers 24/7 access to primary care, specialist, urgent care throughout our communities. We are really designed to be a value-based care organization. We've been participating in ACOs since the inception of the ACA, and we participate in every type that exists. We have upside-only ACOs, downside ACOs, government ACOs, full risk capitation, and a number of direct-to-employer arrangements. We also have something that's, I think it's increasingly common in health systems as they continue to expand and diversify, and that's an entire pharmacy division. Pharmacists who don't necessarily dispense medicine, rather they're analysts and they scrutinize the medicine that our patients and our communities using. And it's been particularly valuable with our direct-to-employer contracts, being able to identify that some of their employees and dependents are on overly expensive medications unnecessarily, and there are very easy alternatives they simply didn't know. And now that we have access to that kind of data, which is important in an ACO or an APM, alternative payment model arrangement, that allows those kind of decisions to be made and the best thing to be done for the patient.
Great, thank you. And Wyatt, how about United?
So at UnitedHealth Group, we have on our care delivery arm, which is Optum Health, we have about 5 million individuals who are in fully accountable risk delivery models. And Kyle, you kind of walked us through, but think of this as the entire healthcare spend that's being managed with the payer in the background. And we work with over 100 different payers. So you've got a payer who's often contracting with the government, and then you have a payment that is coming from the payer to a provider group who's being either contracted or employed at Optum Health to manage these lives. And what's super interesting is that in this construct, we see, as Barry touched on in your first comments, we also see substantial improvement in patient outcomes. And we've published this with scientists we work with in the peer-reviewed literature, but we see 20 to 40% decrease in acute hospital admissions, similar with ER visits, unplanned ER visits, where we'll see a 20% drop. When you look at conditions that are well known to cause frequent visits to ERs like COPD, see a 45% drop. So think about almost cutting in half a senior who has COPD, their visits to the emergency department. And as we all know, I think it's just worth calling out, this means far better experiences and quality of life for those that we're serving, right? You're spending much less of your time in that, scary and frankly sometimes frustrating ER environment where you're waiting and you're not sure what's going to happen. And instead you're getting care at home, and models that are fully accountable actually incent both payers and providers to engineer systems to make sure that you're staying well and you're compliant, you understand your medications, you're compliant with them. Sending a nurse into the home to monitor your home environment is something we do on a regular basis. Making sure that people have a phone number to call before, when appropriate, before 911, where they can speak to a clinician who's knowledgeable and has access to all their medical records. And we can send a team, say a nurse practitioner, out to their house, even on an acute basis, to help manage a situation. And maybe they can safely be managed in their own home. So we see substantial improvement of outcomes. We also see a lowering of total cost of care. And this is also important when you think about the health policy perspectives, is seniors in Medicare Advantage will spend about $2,300 less a year per person. And that's an average, but it's also, if you're in a Medicare Advantage, you have guaranteed maximum out of pockets, which you don't get in fee for service or traditional Medicare, right? So you have sort of a backstop that tells you, hey, it can only go so far. So for those on fixed budgets or of limited resources, programs like these are super appealing.
That's great. I mean, as you were telling the examples, I think everyone can imagine in their own mind the last time they had a frustrating, ER visit, and yeah. So what about how each of your organizations train providers so that value-based care is not only focusing on being a payment model? What do they need to know to fully leverage wraparound services for patients? How do you get them engaged? And has the understanding of value-based care evolved among providers, payers, and of course patients? Do patients know they're in it? And who would, let's say, Kyle, why don't you go first this time?
Yeah, I think it's a really important point where it is much more than just a payment model. At the core, it's a different way of truly practicing medicine. And so the way I would think about it is it's a team sport versus an individual sport. And so it's everyone from all the way on the front end, the actuary team, to our clinical teams, care managers, care coordinators, and social workers and pharmacists. And there's a wide variety of team members that play a role there. And they all play a role to ensure that care is going to be delivered at the right site of care at the right time, which is ultimately going to ensure that unnecessary admits and readmits are not happening across the system. And that's where we spend a big area of our focus around training providers, is how to make that transition to a care team model. Because at the end of the day, the patient is only in the office a very, very small percentage out of the entire year. Most of the work that we're providing is happening outside of the four walls of the physician practice. And that transition is complex for a lot of providers into that care team model overall. So we spend a lot of time around that.
Barry, how about you?
Well, I think it's a great question, because it is most certainly a paradigm shift for the providers. Maybe less so as the years pass, with the new grads coming out being trained in some element of value-based care, we still have a large portion of our population that have been working for our health system for 10, 20, 30, 40 years. And they were raised in an environment of fee-for-service. So this is a very definite shift. So to get them there, it requires a lot of education, focusing on the big picture to get folks out of their silos and to help them understand they need to work differently. They need to work, as Kyle mentions, more collaboratively in a more integrated fashion. That might mean that there's more work for a particular provider, let's say a primary care doctor, who historically and in a fee-for-service model, if a patient might need a specialist consult, they would just hand them off. However, in many cases, they don't need to hand it off to the specialist because many times that can lead to more testing and delays for the care. The primary care, in some cases with the specialist offering advice and information, can handle that patient themselves. How much better for the patient to have that issue managed and cared for in one visit rather than strung out over multiple, and it would produce a lower cost. It's also different for health systems because in the past, they've been able to kind of push everything toward the hospital. The hospital was kind of the center of the universe for many health systems. Now they're seeing the need to have, like MemorialCare does, these ambulatory sites spread throughout the community where the same care can be delivered for a much lower price point, much closer to the patient's home. Now that takes money away from the hospitals. So my hospital executives might say, wait, what are you doing to me? You're taking money away. But they know in the big picture, it's the right thing. And that's what value-based care is about.
Great. And how about you, Wyatt?
Yeah, two quick add-ons to these great comments. One is really like the notion that this is a paradigm shift, especially for clinicians. Most of us, certainly me, way back in the day when I was in medical school, was really trained deeply in how to intervene in a crisis or how to diagnose a problem once it had manifested, but very little training. And to this day, I would submit far too little training in how to get upstream and diagnose conditions before they're a problem. And I think for a lot of physicians, that seems, to this day, that feels a little bit odd. Why am I trying to diagnose something that might be asymptomatic? But you could think of what you could prevent down the road if you identify a condition before it's a problem. You would also ask Maria about the consumer, the patient, and all of this. And I think two things. One is the nomenclature, value-based care, is not well understood or known, right? Am I in a value-based care program? Most patients couldn't tell you if they are. And I think that's okay. Like, let's not try to educate 300 million plus people on what value-based care is. Rather, let's try to meet them where they are. When you're in line in the grocery store, the person standing in front of you or behind you, if you were to ask them, what do they wish their healthcare experience in the U.S. offered, most would tell you something to the effect of they wish that they had a team around them, to Barry, to your point about team-based care, that focused on keeping them healthy and well. That's what's missing. They also most would go on to say, oh, of course, if I do get sick or do get something serious, I want a system that has my back and can get me well again. So it's those two components. And as a fee-for-service sick care system, we're pretty good, not to say there's a room for improvement, at the sick care when you get something serious. Most clinics and hospitals do a pretty good job. But where is that team when you want to, in the months and years before a condition becomes a crisis, where's that team in picking it up and helping you with low-cost methods, even diet and exercise, much less a simple pharmaceutical intervention to help you navigate that and not end up in an emergency department?
That's a great point about what most people would probably say. It's true. So maybe switching gears just a little to talk about partnerships between the government, the private sector, across healthcare organizations, with each other, with community-based organizations. They are essential, I think we'd all agree, to scaling value-based care. So let's just explore for a few minutes how they play out in practice. So Wyatt, we brought up Medicare Advantage before, so let's dive into that a little. Medicare Advantage is often seen as a leading public-private value-based care model, and it is the primary delivery vehicle by which value-based care happens. So let's just spend a few moments. Can you tell us what you see as its major successes and how can it be improved? There's a lot of talk about that these days.
Yeah. Well, I think its major success is the number of seniors who have signed up for the program. As you know, Maria, we all, when we turn 65, our current construct, right? We go into fee-for-service Medicare. We have Part A, Part B, and Part D, and it's very complicated. We have to figure it out. Or we can choose to go into Medicare Advantage. And the fact that over half, or 33 million seniors, are taking that extra step and signing up for Medicare Advantage, I think tells you a lot about the success of the program. So it's been honestly wildly successful. And I touched on the out-of-pocket minimums and control of your expenses, but I think it's also worth highlighting this comprehensive care model focused on keeping you healthy and well, which we've all touched on, but it's a game changer. And when you're a senior, you actually can benefit not only from these additional types of benefits like dental, hearing, eye care, and some additional types of benefits that vary a little bit, but help you manage both your spend and your health and wellness. But you also have that team that's focused on keeping you healthy and well. And I can tell you in our case, and this I would argue is true for most Medicare Advantage care providers, is you're incented to figure out how to partner with community organizations, both entities that you pay for that are partners, that are businesses and startups and things that have a solution for maybe a specific disease like kidney care or heart care or diabetes or depression. We do a ton of that. So we bring in partners to help manage these complex diseases. And similarly, we keep a list in every community that we're in of the community organizations that maybe it's Meals on Wheels, maybe it's a volunteer organization that provides seniors with a friend or a companion that either calls them or stops in or both. And the list is long, but it's really sewing together all these opportunities and coordinating that care. So it goes beyond just what happens in the clinic. It's, can you bring a nurse into the home? Can we have a volunteer organization that touches that person's life so they're not lonely or food insecure? And all of those things have a significant output in terms of improved health at lower costs.
That's great, especially the loneliness part. And just,
Yes.
I mean, yeah. So Barry, HLC released a report, as you know, back in April that showed mixed results for the Center for Medicare and Medicaid Innovation, CMMI. The report identified some strengths to build on and also some areas to improve, such as transparency and stakeholder engagement. Since CMMI is often called a catalyst for value-based care transformation, we wanted to ask you, did you agree with those recommendations? And also, can you discuss where the private sector is leading beyond CMMI? So maybe both comment on CMMI and then what else are we doing?
Absolutely. I think it was a very important report. And some might view the mixed results as reasons to question the pursuit of innovative value-based care models that CMMI has worked to advance. What the CMMI work is doing is testing in the real world a variety of approaches and measuring the impact on quality of care and the impact on federal expenditures. And it might be disappointing when some of the models don't produce the outcomes that were anticipated, but we can learn a lot from those that did not deliver as we expected. Both the government can learn a lot and the private sector can learn a lot. It's important to note that none of the models that CMMI initiated showed a degradation of quality. So quality was the same or improved in every model. The mixed results were around cost savings. One lesson from that I believe CMMI is embracing, and was certainly a recommendation in the report, is in fact, as you point out, for greater transparency into how the models work. It was a little opaque with some of the models, and providers weren't exactly sure how the model was going to move forward. Second, greater engagement of stakeholders. Work with the people who do this stuff for a living. I might also add a third, and maybe this is because I'm sitting in California where we've been doing managed care for half a century. The models needn't be the same across the entire country. There are very different drivers and different levels of experience in various parts of the country. And so doing geographic-based models, I think more significantly would be helpful. This is going to be a very iterative process, but I am convinced that CMMI can be a catalyst to move the entire industry toward value-based care. In fact, we're already seeing it. The private sector is leading into value-based care, and they can be a bit more nimble than the government has the ability to be. They've introduced a wide range of products to employers and consumers, some of which borrow from the learnings of CMMI. But I think it can work in reverse too. I think CMI can look at some of the models happening in the private sector to see where they might be able to adapt their models. We're seeing an increasing number of employers, both large and mid-sized, incorporating value-based care plans for their employees and dependents. And the experiences from those, I think, will be invaluable for the entire industry to continue to move forward. One of the challenges with all of this is that it is indeed an evolution, and it's not progressing as quickly as I wish it would. From a provider perspective, it puts you in a difficult spot. You have kind of the old adage of one foot in the dock and 1 foot in the canoe. That's a very uncomfortable spot to be when some of your business is fee for service and some is value-based care. And the incentives are different in each of them. The way the providers work can be different in each of them. And so if we can accelerate the movement to value-based care, it'll eliminate that challenge.
That's great. A lot of really good points there, especially on some of the private sector innovations too, and what we can learn from them. So Kyle, so while CMMI runs pilots, the Medicare Shared Savings Program, MSSP, is traditional Medicare's permanent value-based care platform. So in case people tuning in didn't know, so what are its strengths and where can it be improved? We'll leave that one for you to tackle for us.
Sounds great. Yeah, so the MSSP program, it's the largest value-based care program in traditional Medicare. So outside of Medicare Advantage, there's over 10 million participating patients in the program today. And anytime that a provider can earn a percentage of shared savings, that's obviously incentivizing the right behavior, as we've talked about here. It's a great aspect of the program, which is accelerating, I would say, adoption in value-based care more broadly. There's also stability in the program. As I said before, it's been around for 10 plus years. Stability in these programs is important so that whether it's Barry or Wyatt or companies like Wellvana have the ability to underwrite that risk and know what we're getting into as we look to drive the adoption of value-based care. So stability there is very important, and that program certainly has been over the last decade plus. As I think about opportunities within the program, certainly the ability to have a higher percentage of shared savings to the upside and to the downside is important. So right now, the upside is actually capped at 75% of savings, whereas in programs like Medicare Advantage, you could earn up to 100% of the savings that you're creating. So more upside or downside could be an opportunity there. The program itself today, you're paid once a year for the most part. There's exceptions to that in some of the ACOs, but on average, it's annually. And it's 9 to 10 months after the end of the former program year. And so accelerating some of those payments we think will increase the adoption of those programs because it helps with working capital needs of the companies that are taking the risk there and the providers that are taking the risk. And then there's elements around predictability of the program. So today, I talked about benchmarks before and what that means. There's some of the trend information in terms of how they set those benchmarks. Obviously, it's pretty complicated formulas behind there, but it's not based on actual trends. It's based on an estimated trend or a hypothetical trend. And so more predictability within that, we think, would be helpful to continue to drive more adoption of value-based care, in particular within the MSSP program more broadly.
That's great. Some very actionable observations and recommendations. So Wyatt touched on this a little bit. Let's talk about partnerships outside of government between payers and providers, with vendors, community-based organizations. So maybe we could just, and I'll turn to you first, Wyatt, but talk about what makes them successful and also how can policymakers support them? They're outside of government, but they could use government support as well.
Yeah, well, I would suggest that anyone who is in a solution mode for value-based care should work to acquire the clinical data to show that improved outcome. And ideally, with that, they can show whether it's derived from the clinical study or its own economic analysis, the impact on healthcare spend, because those are the two elements that we all are looking for when we're providing value-based care. Does it result in better clinical outcomes? And does it help to stabilize or lower costs of care so you can invest in health and wellness? I would submit that in the sort of the digital and telemedicine health space, there's too many unproven solutions out there. Then when it comes to community organizations, I have a lot of fondness and respect for these organizations. They're often getting by on a shoestring, and they are providing incredible value and work in filling kind of what I call gaps in people's holistic well-being, right? So traditionally, when we've talked about U.S. healthcare and clinical medicine, we're thinking of, the technical medical expertise and interventions that can be provided. And we've often left off the social drivers of health that are probably more important than the actual clinic you hopefully have access to. And so it's really important. And I think that those coordinating care like Optum Health or MemorialCare or others or Wellvana, they're interested, we're all interested in knowing about you and having an effective partnership. And from a particularly a local and state government, I think finding the right ways that are sustainable to support these community organizations is really the key. Is how do we create within your community, how do you create a awareness of organizations that are providing valuable services? How do you then help coordinate access to those services? And then how do you make sure that if it's providing a valuable need and fulfilling an important gap, how do we make sure that it's sustainable over time, which is often a blend of public and private partnerships, philanthropy, et cetera.
Right. Kyle, do you want to comment?
Yeah, I think there's a couple key areas as I think about the vendor side of it. Data transparency is a real issue in value-based care. Oftentimes, as Wyatt said, the data we're getting is largely pretty lagged and not giving a full, complete picture of the patient. And so we're investing heavily right now with clinical vendors so that we can align all the clinical data from across the healthcare ecosystem of the patient with the claims data that we're receiving. On the claims side, it's actually an area that traditional Medicare is probably farther ahead than some other payers out there. We get full, complete picture for multiple years on each patient from a claim perspective. We don't necessarily always get that on the Medicare Advantage side. And so I think that's an area of opportunity, is to standardize information sharing across that as well. So I would say data transparency, interoperability broadly is a key area for us as we think about partnering with vendors or other community-based organizations. I think the other side of that too is just alignment on outcomes as we think about underwriting and taking the risk that we take to help drive a better cost of care and a better clinical outcome for patients. That always works best when there's win-win scenarios within that. So things around, as an example, alignment on supplemental benefits, right? And making sure that, we're aligned with the benefits that United, as an example, would be putting out for the populations that we're taking risk on, or other ancillary programs that could be available in the community. There's a lot of them out there and a lot of opportunity, and making sure that the risk-bearing provider, has ownership of that if they're ultimately taking the risk around that.
Great. And Barry?
You bet. Well, we've touched upon ACOs, and ACOs are a form of partnership in the private sector between a health plan and a provider system, offering a delivery network that is prepared to accept risk for both quality and for cost. There's a lot to be learned from those partnerships, and they're contributing to the refinement of the models, and we continue to improve upon them. By example, early on, many of the ACOs, both in the government side as well as on the private side, used what they called an attribution methodology for assigning patients to ACOs. Attribution simply meant that MemorialCare, you're responsible for this group of patients in your community. and we're going to hold you responsible for quality and for cost and for access. But the patients don't even know they're in your ACO because they don't even know an ACO exists. We're attributing them to you because they've used your health system in the past, not exclusively, but they've used it more than they've used others. And we had no way to communicate with those patients to begin education, to begin preventive measures. So the attribution methodology was an interesting, maybe understandable entry point for ACOs, but there's only so far you can go, only so many improvements you can make when you don't know the people are even in your ACO and they don't know it either. The alternative to that is what's called the network model or the delegated model, where the folks choose to be in your ACO. They're aware of it. You have kind of unfettered access to communicate with them, to educate, to work on preventive care. And that's one of the areas I think the government can kind of keep their eye on to make sure that kind of communication between the provider system that's at risk for quality and costs can be able to access and communicate with those patients more freely. Some of the other partnerships that we're seeing are in that category that I call direct to employer. And historically, those have been with very large employers like a Boeing or a Qualcomm or a Google or a Cisco that have large infrastructures. They are self-funded for their health plan, so they're ERISA plans. And they decide to contract with a network, maybe not one health system, but a network of providers in a particular geography. We're seeing great success with those in bending the cost curve. In fact, we have in the Western United States, we have for Southern California, the contract with Boeing. We've had it for a number of years. And it's just, they can choose a PPO option if they want to, and they can choose the MemorialCare ACO network. We've demonstrated we can actually bend the cost curve more significantly than any other product they offer to their employees and dependents because of the data, because of the prevention, because of the alignment of incentives. In the old days, it was direct to employer contracts were really just kind of the domain of the big employers. There are models now where small and mid-sized employers can play in that same space. In fact, we have a local bank, F&M Bank. I think they have 17 locations in Los Angeles and Orange County. So it's not a big employer. They may have 700 employees. And we have a direct to employer, fully risk-based contract with them. We've been able to demonstrate a 40% reduction in cost for the employees that choose our network compared to the employees in the same company in the same geography that choose a PPO product. So these products work and they're far more beneficial. So my request to policymakers would be to continue to allow flexibility in these kinds of arrangements and reduce regulatory hurdles. And I understand some of the hurdles are age old. I mean, the Stark legislation was put in place during a fee-for-service culture. It simply doesn't fit. Not only doesn't fit, it actually gets in the way of some of the communications and relationships between providers and patients that you want in value-based care arrangements.
That's great. So let's continue with the policy improvements that we'd all recommend to Congress and the administration to advance value-based care. Maybe go back to start with Wyatt. Like what are, 1, 2, or 3 that you would recommend that the policymakers really understand and act upon?
Sure. I think for starters, recognizing the need for stability within the Medicare Advantage program. It isn't widely being discussed, but we estimate that the change in coding from version 24 to version 28, which is being laid out over a 3-year period, is about a 9% cut to payers and providers of Medicare Advantage. And it's having significant impact, which combined with increased utilization, which has been a national trend post-pandemic, is putting major stress on both providers and payers for Medicare Advantage. So I think stability in the program would be ask number 1. I think then a few other areas within MA. One is recognizing the importance of continuing to involve and encourage care in the home. There's some, I think, pretty significant misunderstandings out there around what, say, we do when we send a nurse for an annual wellness visit. We call it a health calls visit into a senior's home. because it's often inclusive of what's called an HRA or health risk assessment, but it's much more than that, and it includes doing medication reconciliation, a social drivers of health assessment, a behavioral health assessment, and of course physical well-being and medical concerns. When I've been on these ride-alongs with our incredible nurse practitioners, we had an individual who was discharged with a week prior with a stroke. She and her husband didn't know how, they were told to follow up with a neurologist, but didn't know how to. So our nurse practitioner arranged for that follow-up care for them right there in the visit in their home. So there's so much to these kinds of visits. I think actually care in the home is likely to be a new frontier that offers incredible value, especially to those who have more difficulty with ambulation or transportation insecurity getting to the doctor. So home care is one. End of life care, I think, could use a little bit of attention in terms of making sure that those providers who wish to can provide comprehensive solutions. And then, Barry touched on this, but I think continuing to evolve both the Medicaid and the employer markets into full value-based construct is something that warrants ongoing attention from both CMS and, as appropriate, legislative bodies.
That's great. Those are very good. Those are good ones. How about Kyle? I know you have some.
Yeah, I think there's a few, and I've mentioned some of these I think previously here, but I'll just reiterate here quickly. I think the first around some of the benchmark trends, right? So right now there's an estimated or hypothetical trend rather than an actual trend, and in some cases that trend is out 5 years, which is very difficult to estimate what that's going to be over a 5-year period. And so as we think about some of the benchmarks in the ACO programs, focusing that around actual trends versus estimated is a key thing right now. Second being the successor program around ACO REACH. I mentioned before higher levels of risk potentially within the MSSP program, both upside and downside is an opportunity. A version of that is a CMMI program called ACO REACH that goes away at the end of 2026. And so understanding successor programs to that is another area that we're focused on right now. And then lastly, I mentioned this before, but data interoperability, right? The more structure that we can get around patient clinical level data to support advanced care planning, support care coordination, care management is critical. And then from a Medicare Advantage perspective, the de-identified data that we can get within traditional Medicare today is significantly better than we can get in MA. It's really subject to the payer on the MA side. And so what that allows us to do is making sure that we're taking the right actions based on history and current information for patients, which we think will support value-based care adoption for risk-bearing providers in partnership with MA as we think about that care continuum and making sure we're starting in that right level of risk effectively.
Great. Thank you, Kyle. Barry, any others you want to add?
You bet.
Yeah.
I mean, again, there's ample evidence to demonstrate the increases in quality and reductions in costs in value-based care products. One of the barriers to provider systems getting into those are the upfront costs. In fact, I saw one of the questions come across about, is value-based care more difficult in a rural environment? And for a number of reasons, it may well be, in part because rural hospitals tend to have very thin, if any, margin and a very struggling balance sheet. And to invest in something that for your fee-for-service patients is going to reduce your revenue isn't really a good business model. Spend money over here so I can make less money over here is not the way you want it to go. So consideration by Congress administration to offset some of the upfront costs that are necessary for providers to move away from fee-for-service to value-based care models. I would offer, particularly for the government, that the savings will far outweigh those costs over time. But providers many times don't have the cash flow to absorb that, and so they may need some assistance. I've already mentioned the ability for more free-flowing communication with the individuals who enroll in value-based care plans. We want the providers to be able to communicate with them as early and often as possible. It makes an enormous difference to make sure they get the right care in the right place at the right price. Also realizing, and I think Dr. Decker touched upon this, that some of the savings might come relatively quickly in value-based care models, but some will take a few years to manifest. So we need to let these programs continue for a few years to be able to realize some of the savings that can come from them. And so creating that stability over the course of time will be helpful. And then finally, and this has been in the media a lot, and I think also in the minds of Congress a good bit, there's a lot of scrutiny on prior authorization today. Some of that's warranted, I would offer, but appreciate the way that prior authorization is handled, and the necessity of prior authorization really spans the gamut. And we don't want to throw the baby out with the bathwater. In some cases, prior authorization makes certain the patient gets the right care in the right place. They just don't jump to, if an ultrasound will do fine, by golly, a CT is better. Not necessarily so for a host of reasons. So I think we just don't want to react too abruptly or too significantly to rein in some of the issues we've had with prior authorization. It needs to be a thoughtful approach.
That's great. Thank you. Well, thank you all. This is excellent. Now let's go right into the Q&A. We already have some good questions, and Barry, you touched on one of them about how difficult is it to administer value-based care in rural areas. But let's go to this one. How are your organizations incentivizing providers to deliver accountable value-based care in diverse settings across the care continuum? I guess we touched on rural, but and maybe some other areas that if anyone would like to go first.
Happy to address our approach, because we have fewer than 10,000 physicians that we employ, and we have a group of about 80,000 doctors who are independent or are employed by organizations like yours, Barry, that we work with, right? And in those settings, it's really a partnership, and we work to provide training and what does a value-based care patient need clinically, what are the clinical models, how can we provide some of that support? And it's true that the documentation, the kinds of things that measure, they're known as HEDIS measures and others, CAPS and HOS for patient experience, they require a different type of documentation. And so our approach is to do the training and then provide a financial incentive that's modest, but not so modest that it's nothing, so that independent primary care doctors can benefit financially from providing high quality value-based care. And that to us has been part of the secret sauce of really making it exciting and frankly helping to reinvigorate very challenging careers in primary care that have turned into quite a grind in the pure fee-for-service environment.
Kyle or Barry, would you like to comment?
Yeah, I mean, the only thing I would add is just that as we look at our network, about 50% of it is in pretty rural areas. And so value-based care, does work in rural areas. It is certainly different in terms of the areas we might focus on, depending on the market. To Barry's point, every market is different. But we've been very successful in rural areas with about half of our business and thousands of providers in those markets.
I'll just comment. Dr. Decker made reference to incentives. We know incentives influence behavior. They also educate you as to where am I trying to go? What are the metrics to get there? How often do I hear it reported back to me so I know my progress? So it is a fundamentally different relationship, at least for a health system, with physicians, whether they're employed by us or independent and aligned with us in some manner or form, where we align the incentives with the health of the population, with greater access. Patients can't be waiting days or weeks for an appointment, and that's all measured. And it's a fundamentally different model than under fee-for-service. So it is a different infrastructure, a different relationship between the health system and the providers.
Barry, just to build on that, I mean, I think sometimes there's a feeling of maybe our incentives somehow a bad thing. And, I think just to make it really practical, wouldn't you want your primary care physician to be rewarded for making sure you get age-appropriate cancer screenings like mammograms and colon screens? Because often people don't, right? Often it falls through the cracks in fee for service because there isn't any oversight or rewards unless you're in an ACO program or an MSP program, which is moving you to value-based care. And I would also submit that whether we call it an incentive or not, fee for service is basically a volume incentive, right? Oh, the more I see, the more I do, the more money that comes in. So whether it comes to me directly or comes to my organization. And so I think we should just recognize that all of the practice of medicine has incentives. So let's try to align those to the kinds of care models and delivery models that help keep people healthy and well.
It seems like this next question, maybe you might all have to think back a little bit. What's the most significant internal cultural shift or organizational challenge your organization or company faced when transitioning to value-based care models, and how did you successfully navigate it? But Barry, I guess it's been quite a few years, but can you share anything?
Oh, yes, because I remember them well. I think the question is phrased beautifully because it is definitely a cultural shift. It's different from what most people that work in healthcare were ever trained to do, ever experienced for the vast amount of their careers. So it is a different mindset. And you just need to continually remind them that, as we add more and more ACOs and alternative payment models and direct to employer arrangements where our investments are to keep people out of our facilities. And when they need to come to our facilities, they go to the right level of care. That is a wild mindset for people. So it's really a lot about education. And quite frankly, we mentioned incentivizing physicians in the right way. Must do the same thing with the administrators within health systems and make sure that our incentives are aligned and get them out of their silos, because that is one thing about the fee-for-service culture, including traditional Medicare. It is clinically siloed, which is not good. It's also financially siloed, which is not good. But that's where people have been raised. And so kind of breaking down those silos has been critical.
Yeah, I would add to that as well. So we're a little bit different in the sense that we don't employ any providers, and all we've ever done is value-based care. And so a little bit different from that perspective. But as we work with providers, whether it's a hospital employed primary care provider or an independent physician that we're working with, I think it goes back to what I said before, which is the cultural transition, as Barry said, into this care team approach, where it's enabling the provider to have the right information at the point of care, but also building the trust with the patient and the provider that the social worker, the pharmacist, the care manager, the coordinator is going to take the right action and keep the provider aware of what's happening when they need to be aware of that, and making sure they have access to all that information. So that whole process is certainly a cultural shift, especially for a hospital system. And that's at the core of what we do every day, is try and train healthcare providers on that transition.
See, having to train patients too, convincing certain patients that it's okay to someone else giving you care beyond the doctor.
I mean, patients trust their physician, right? Mm-hmm. Versus, a cold call from a nurse that they don't know.
Right.
The likelihood of them listening to them is significantly less. And so the buy-in of the provider when the patient's in the office to introduce the care team and here's who your nurse is going to be, and build the trust with that patient is a critical aspect of driving the right change in behavior ultimately for the patient that we want to drive.
So Wyatt, how about you? Is this a continuous journey?
I just build on this, but it is a massive shift when we've grown through acquisition as well as organically. So when we bring on board a well-functioning, busy fee-for-service practice and begin the journey, it's a lot of angst, and it's hard. It's hard work. It takes 3 to 5 years, probably minimum, to just and we prepare for financial losses while we do that for potentially 2 or 3 years. And so, sure, you got the financial losses, but I'm going to focus a little bit on the specialty care, because specialists are kind of, they're kind of been born and raised and practicing often for years in an environment where, as long as they're busy and doing a lot, their administrators are happy. And now you're moving to an environment where you really want them to be judicious. You want them to follow the absolute best evidence-based practice. And for most, that's actually kind of a welcome shift, but it is a shift. And the environment that they've been in. And in metro areas where we refer patients to specialists, cardiologists, orthopedists, et cetera, that are in private practice, and we pay them private practice fees, we monitor them. We actually know who's practicing what appears to us to be high quality evidence-based care, and who is really kind of leaning heavily on the hit go for a procedure or a test button. And we'll talk to them. And of course, sometimes there's mitigating factors, like their expertise is such that they're going to see a sicker type of patient. But once you sift through all that, then you kind of get to, okay, we're going to refer our patients to those specialists in the community that we have a degree of confidence based on data that are providing judicious, thoughtful, evidence-based care.
Well, thank you. And we are at time somehow. This is a terrific conversation. So we really want to thank all of you. We commend all of you for your own personal leadership and your organizations, your company's leadership. We're all really excited to see what happens next. I think we are hearing from the best about how this really can transform care, and just how many opportunities and the commitment here. So thank you everyone thank you all for doing this, and thank you everyone for joining. Continue to follow us not only on value-based care, but the other topics that we work on. We are on LinkedIn and X, and you will be hearing from us again. So thanks again. Thank you.
Thank you.